Hello, everyone, and thank you for joining. I want to speak with you tonight about babesiosis. Years ago, believe it or not, back in the 1980s, there was a massive outbreak of babesiosis in the town where I was working. And within maybe a couple of weeks, I personally saw 17 acute cases in the hospitals full of people with acute babesiosis. How that happened, I don't know. But it started us off on this track of figuring out this crazy disease because back then, no one knew about it. It was not supposed to happen in humans. So let's get started. I want to talk about diagnosis tonight, and then Dr. Dow will pick up on the treatment end of it. So what a lot of people probably don't realize is how common babesiosis really is. In fact, when IGeneX tabulated their tests a number of years ago, it was more common than even Lyme disease or relapsing fever. It was the most common one that they found. New York State Department of Health did a survey, and of those people who have test positive Lyme disease, two-thirds tested positive also for Babesia. Another thing I found out in researching this, Babesia is the most frequently reported transfusion-transmitted infectious disease in the United States. So that's a lot. Maternal fetal transmission has been reported. Another thing people don't often realize, Babesia thrive. They grow and multiply and thrive in tick saliva. So as you know, the tick injects its saliva right upon biting. So the chances are that you can get Babesia as soon as the tick bites. You may not have to have hours or days of attachment. And finally, another thing which I found interesting, people say, well, Babesia is carried by the same tick that carries Lyme disease, the Ixodes tick. And while that's true, it's also, I found, been found in amblyonna ticks and dermacenters as well. So it's actually a lot more than what people expect. IGeneX showed me this interesting map. They keep track of their positive test results by county. And if you look at the map and look at the numbers, between 2019 and 2025, it went from 601 counties tested positive to 944. Now, again, this is just one lab and just their own, select clientele. It's not probably what the CDC might report, but still, it really shows you that this is something that's a real problem and spreading. Another thing, there are a lot of different Babesia species, and it's important to know that because this has impact on testing. In the United States, people know about Babesia microti, also Duncani. More information has been given about Otocolii. Divergence has been found in humans. MO1, the Missouri strain, has also been found. In Europe, there's Venatorium and Cassie. In Asia, there are two other species, the one that's called Duncani-like and KO1. Now, you see in my slide, I said, is this really true? What I also learned doing the prep for this webinar, is that Babesia species often are named nowadays by their genetic sequencing. But in the world of Babesia, a 1% difference in sequence gives the scientists kind of license to call it a new species. But the thing is, rarely are any one species of Babesia having a very specific genome. So there's always genetic drift. There's always slight change in sequencing. We're talking about the 18S RNA sequence. And so it makes it very hard to positively identify and name species. It also makes testing difficult. For example, if you have a test that's specific for Babesia microti, not all microti will be picked up. Maybe some others that aren't microti will be picked up. It makes testing very difficult. And nowadays there's some controversy among the Lyme literate that Otocolii maybe really is the pathogen and not Duncani. Others say, nah, it can't be because we only test for Duncani. That's all we ever find. And when we test for Otocolii, we don't see it. And back and forth it goes. But I'm really wondering, genetic sequencing between those two species is so very close that, of course, there's going to be confusion not only with testing, but actually naming the thing, because you really have to do more than one sequence to one genetic focus to really completely sequence this, and not all labs do that. Anyway, the problem I'm mentioning is even worse if you look at the literature. Here's an article came a few years ago from China. They surveyed the northeastern forest areas, and it was 45 north. I looked it up. It's roughly equivalent in the United States to Wisconsin, Minnesota, and up in New England. And they found bigemina, divergence, microti, Venatorium. They found a thing called HLJ8, HLJ874, MA361.1, HLJ242, Babesia crassa. So their conclusion is that there's a high genetic diversity of species in a relatively small sampled region. And when it comes to testing, it shows you that you really need to have a test or types of tests that will look at not just one specific species. And in fact, to look at a genus level test is probably the most significant thing to do. Clinically, what are the clues? First of all, crushing fatigue. Everybody knows that with Lyme you have tiredness, but with Babesia, especially co-infecting Lyme, the fatigue is terrible. People wake up and they feel like, gee, I really need a nap, and they're still in bed, haven't woken up yet. But the fatigue is really, really extreme. So if you have a Lyme patient whose fatigue is so overwhelming, test or no, you have to think of Babesia. Sweats, chills, fever, that's been reported. But how about the patients who always feel cold? They always feel cold. That's a sign I've found clinically. That's a clue. Migraine-like headaches, which we know about, cognitive dysfunction, shortness of breath, the loss of balance, all these are due to impaired microcirculation caused by Babesia. The magnified neuropsychiatric symptoms that you see in Lyme are a big problem. Babesia makes all Lyme symptoms worse, including the neuropsych ones. Another one that's a clue, an unexplained iron deficiency. Acute Babesia can cause acute hemolysis. We've all seen that, or at least I have. But chronic Babesia can cause low-grade hemolysis, which over time can strip the person of iron because free iron is excreted in the urine, and you can do a urine test for hemosiderin, and that's the clue to it. So if there's an unexplained iron deficiency, think Babesia. Splenic enlargement has been reported. I've seen that in acute cases, but chronic babesiosis, it may not be a high enough rate of infection to actually cause physical enlargement of the spleen, but it does cause it to swell. And patients often complain of left upper quadrant pain that goes away with Babesia treatment. So if someone has this unexplained upper abdominal pain and it's really not GI, and you do a scan, let's say, I've done this, and patients have normal size spleen, but it's tender because it's probably being stressed. And finally, if someone is given Babesia type medication and they get a Herxham reaction, that's very important. Now, concurrent Lyme is also impacted. It's well known that symptoms of Lyme are much worse if someone's co-infected with Babesia, and the treatment of Lyme is impaired. Lyme treatment, when you have Babesia, Lyme treatment itself has to be more aggressive and of a longer duration. Another thing, if you have a patient with classic Lyme symptoms, let's say neuropathy, arthritic joints, swollen joints, and you treat them, and those things seem to clear, but the neuropsychiatric problems are there, they're feeling cold all the time, the fatigue is still there, then you have to think, all right, if symptoms are left over after Lyme treatment seems to have cleared the Lyme-specific treatments, then you have to think Babesia, of course. I'm going to go through several different testing methods that IGeneX offers. One is IFA. IFA is immunofluorescent antibody test. It's a manual test where a blood slide is stained with some basic dye-type stains, and then it's looked under the microscope with fluorescence. The problem is it's a manual test. It's operator dependent. It's even microscope dependent, believe it or not. So because of that, it's both insensitive and having false positives. And the IFAs in general only look at one species, generally microti. If you look at the big box labs, you can see microti, some offer Duncani, but again, it's an old-fashioned IFA test. IGeneX has pioneered the immunoblot. This immunoblot consists of 20 individual recombinant protein antigens for the IgM and 20 also for IgG. Each antigen is able to be individually detected and individually measured. So it's like having 20, if not even 40 separate looks at the Babesia organism through this one immunoblot. Studies have shown it's more sensitive and more specific than the IFA. It's able to detect all the major Babesia species, and it's the only test available in New York State for Duncani. Now, how can you make these tests, the serologies, more sensitive? We don't have data on this, but there's a lot of anecdotal speaking among the Lyme literate that if someone is pre-treated with anti-Babesia medication or fibrinolytics to dislodge some organisms, and then you run the serologies, the chances are that you might have a higher pickup rate. There are no controlled studies, but there's enough anecdotal reports of this that I did want to mention it. Here's a simple table that shows you that however you look at it, comparing the IFA to the immunoblot is better in every single measure than the IFA. Now, not is it more sensitive, but it's much more specific. Now look at this table. All the different tick-borne pathogens that are the major ones that we know about have been tested for cross-reactivity on the Babesia immunoblot. Even E. coli, even normal controls, has not been a single false positive in any of these studies. So the conclusion is if you have a patient whose Babesia immunoblot is positive, you really should believe it because they haven't seen false positives. All right, let's talk about the Babesia fish. That stands for fluorescent in situ hybridization assay. Now, this is also a blood smear. The Babesia are stained with an RNA probe that's fluorescently labeled. And what you see on this slide, you can see it right there. It's a picture of the organism. When comparing this to a standard stain smear, the sensitivity, and this is published, is 500 times more. So early Babesia, within the first several days during the acute phase, you can get positive peripheral smears using a standard smear. But after the first week or two, those disappear and you really have to rely on the fish. Another interesting thing, the fish can detect organisms even embedded in the biofilm. The fish test is a genus level, so it gets around all the confusion of what species is it, is it an American, is it European, is it Asian? Doesn't matter. It's a genus level detection. As I said, not only is it very good, but it's also highly specific. I didn't develop a table for you, but when the validation studies were done comparing with a variety of other tick-borne diseases and others, there was no cross-reactivity. So basically, if you get a positive Igenix Babesia fish, you believe it. Another very important thing, because it's looking for the RNA of the organism, a positive test means the day the blood was drawn, the patient was actively infected. The half-life of foreign RNA in the blood is measured in minutes. So it's not like someone, well, that's a lingering infection, there's some nucleic acid still lingering. No, we have RNA aces in our bloodstream. And if there's a positive Babesia fish, it means within minutes of the blood draw, that person was infected. Now, there's one caveat. You have to be aware of false positives. Some other labs are causing trouble. Igenix has a very high standard for calling it positive. You have to have three things. Number one, of course, you have to have the fluorescence. Number two, you need to see the typical Babesia morphology. What you see are usually ring forms or what's called a Maltese cross. You can see pictures of that. And located within cells. Only in a very acute, overwhelming infection will you see free-swimming Babesia. But in the 99% of the time in the common infections and also in all the chronic ones, you just don't see free-swimming Babesia enough to make a note of it. So you have to have those three things. Some other labs will call a positive just by seeing fluorescence. But the thing is, a stain is a stain. It can precipitate, it can stick to a slide. So if you see these things, what Igenix calls stain dots, that's not enough. You have to have the morphology. It has to be within a cell as well as the fluorescence. Third test is the PCR. It's a direct detection of the nucleic acid. Here, of course, it's DNA. It's a direct detection. It's for microta and duncani specifically. A positive test generally indicates an active infection. Cell-free DNA in the blood is rapidly broken down. The half-life is less than 2 hours. However, if it's within the cell, intracellular DNA may persist for the lifespan of the cell. And red cells, as you know, have a 120-day lifespan in the blood. So a positive PCR may not mean acute infection at the time. PCR is not very sensitive, but it's very highly specific. The low sensitivity is simply because not only is there a low organism count, but there are chemical inhibitors in the blood that interfere with the PCR process. And in the real world, that limits sensitivity. To get around that, Igenix has what I'm calling the fourth test. It's their culture-enhanced PCR. In this case, they take the blood of the patient and they incubate it in an incubator with culture medium. And after 2 weeks, the positives are confirmed by a special, highly validated PCR. And here, in this case, a positive result indicates the presence of living organisms because it's a culture. It's also a genus level test and able to detect not just microta and duncani like the PCR, but all the different species of that genus, including some really strange atypical ones I've seen, including things that you find in cattle, in dogs, even Colpodella, which is a free-swimming protozoan that's rare, but they found it. Compared to a straight PCR, sensitivity is at least 10 times higher. And that's because not only does culturing amplify the number of organisms, but the culturing process removes those PCR inhibitors. So when do you do this? Well, it's tests that you do when you really need maximal sensitivity, especially in an atypical case where you have symptoms that don't seem to fit. So when you're doing a direct test like a fish, a PCR, or the culture, When's the best time to do it? The best time to do it is when the load of pathogens, the load of Babesia, is expected to be the highest in the blood. So it's, of course, very early in the infection before the effective immune response develops. You also get a higher load during symptom flares. So if you have a patient whose symptoms are waxing and waning, try and get the blood done at the time of a symptom flare. And Babesia specifically during the chill phase. Patients will have the chill, then they start to sweat, and then things settle down, then we'll get a chill again. Get it during the chill phase. You get a much higher yield that way. If someone's on Babesia medication, anti-Babesia meds, that can decrease sensitivity. So if they're on, say, Tafenoquine, whatever, don't do the direct testing, these two tests or these three tests, if they're on the treatment. I'd never recommend you stop treatment just for the sake of getting a positive test. But on the other hand, if they're on a medication break or if they're not yet treated for Babesia, then that's when you can do it. Again, some anecdotal hints. Some clinicians pre-treat before testing. Again, fibrinolytics can release some sequestered Babesia. Anti-Babesia meds may help to enhance pathogen release. Some recommend physical measures, massage, and so on and so forth. These are anecdotal, they're not proven, there's no firm studies, but there's enough information about this running around on the message boards that I tend to believe it. So I'm going to close with the recommendations. Always recommend you do the immunoblot. The results are very minimally affected by recent or ongoing treatment, so that's great. Besides giving information about positive or negative, also what species, because immunoblot does speciate, it also gives you insight into the immune status. If you know someone has babesiosis and their immunoblot, which is a B cell measure, is negative, then you have to start to question the integrity of their immune response. Another thing, this is tricky. In Lyme disease, Borrelia burgdorferi can affect the epitope change in early infection where IgM disappears and IgG forms. A lot of us have all seen that in Lyme, a Lyme patient can have a positive IgM for Lyme disease late into the illness. And that's a phenomenon of Lyme disease. But what a lot of people don't realize is when Lyme is present, this will happen to other concurrent infections. So if you have a patient with babesiosis and they get an immunoblot and there's been a chronic infection, not just acute, and the IgM is persisting for Babesia, that's a clue that Lyme may be present also, regardless of what other testing you may have done. So again, a late positive Babesia IgM may suggest a concurrent Borrelia Lyme infection. So we always recommend the Babesia immunoblot, and we also recommend you add the fish because the Babesia immunoblot is an indirect test. The fish is a direct test. By using two dissimilar methods, you increase the test yield. And finally, we really recommend you add the culture-enhanced PCR to maximize sensitivity, especially if it's an atypical case, clinically or atypical organisms are present. So that's my end of the diagnostic part, and we're going to turn the screen over to Dr. Dow, if I know how to do it. Let's see.
Well, thank you everybody for listening in this evening. I'm going to be talking about kind of high-level background in terms of what treatments are recommended and why. A little bit about the history of drug development for babesiosis, what 60 Degrees Pharma is doing as a company related to Tafenoquine, and just highlight some of the gaps in the existing standard of care. I have to put this disclaimer up because I will be making some forward-looking statements as it relates to our clinical trials. I also need to disclose that I'm not a physician. I am a shareholder in 60p, and my comments about treatment are either based on guidance or my personal opinion about the status of the literature. So as Joe outlined, there is lots of different tests for Babesia. And what happens when you test positive for one of them? Well, then it starts a potential treatment cascade, and the choice of treatments depends on what kind of test result you got, what kind of medical history you have, and what kind of symptomatic illness you have. And that's outlined here in this table. So starting from the top, if you're asymptomatic and healthy and you happen to be donating blood and tested positive, then the current treatment guidelines as recommended by IDSA is to treat and monitor with testing if you have risk factors for acute infection. I am referencing the IDSA guidance as it relates to treatment because, at least at the moment, that's the only source of professional society guidance as it relates to treatment regimens. Although, of course, in the ILADS and Lyme treatment community, there are lots of variations of that starting point for recommendations. So if you've got flu-like symptoms, you've probably got acute disease. If you're immunocompetent, then the current guidance recommends treatment with one of the regimens for 7 to 10 days. If you have risk factors for severe disease or for relapsing disease, for example, if you're splenectomized, immunosuppressed, if you're taking, if you have a malignancy or you're taking chemotherapy or immunosuppressive drugs, then the guidance at the moment is to extend the frontline regimen for at least 6 weeks, including 2 of which the parasites are not detectable by smears. If you happen to be high risk and you have relapsing or recurrent illness, then the standard of care is usually an extended series of regimens until you test negative on a PCR. Of course, all of what I just said relates to acute illness and may not necessarily be related to chronic babesiosis, which I suspect is of more interest to most of the folks that are listening in. And here it's a much more complicated situation because the symptoms can have been present for years, can overlap with other things, and you're dealing mostly with a low-density infection that isn't recognized or detected by most of the commercial big box diagnostic companies. So as Joe said, it makes it very challenging. And of course, the official guidelines don't recognize this phase of the illness. And there's a lot of questions about what is the species that causes it. So these are the current regimens that are recommended. So frontline treatment is Tafenoquine and azithromycin, or clindamycin and quinine. The combinations in the table are what are currently recommended for treatment refractory disease. And you'll see the common theme is a combination of various different kinds of the individual agents that are used to manage acute disease in people that are immunocompetent. None of these treatments are approved by FDA. No regimens have been evaluated in chronic babesiosis, and there's no ILADS treatment recommendations. And so we don't really have a central place you can go to see treatment regimens that have been modified or adapted for chronic illness. This timeline highlights how we got to where we are and some of the gaps in the existing treatments. So back in the 1980s, when babesiosis was a new thing clinically, it was treated with a drug called pentamidine, which was developed for African sleeping sickness and leishmaniasis. It was not curative, and it had some nasty renal toxicity associated with it. Then in the 1980s, a few case studies came out in the literature showing that the combination of clindamycin and quinine was more effective. It would eliminate the parasite, but extremely poorly tolerated, particularly the quinine component of it. In 2000, there was a New England Journal paper published, which was a randomized clinical study comparing Tafenoquine azithromycin with the current standard of care at the time, clindamycin quinine, and I'll share some of the data from that in a minute. And then between 2022 and 2026, Tafenoquine, which is approved for malaria prevention, and Vivax malaria began to be incorporated into atovaquone-containing regimens to treat treatment refractory disease in immunosuppressed patients. I'll share some of the work that we're doing that we hope will lead to a new drug application submission to FDA for tafenoquine in 2027. And then I'll just briefly touch on, even if we're successful in that endeavor, what are some of the gaps that still need to be solved? So these are the data from the clinical trial that was published in the New England Journal in 2000. And essentially, you can see in the survival curve that over time, the percentage of subjects with detectable Babesia DNA by PCR followed essentially a similar trend. And that was believed to be evidence that these two drug combinations are similarly effective. And then on the right-hand side, which highlights the symptoms that were reported by the patients, right down at the bottom under during therapy, you can see diarrhea, tinnitus, decreased hearing, rash, and vertigo. Those are all symptoms of quinine mostly, adverse events associated with that particular drug. And you can see there's a significant difference in those side effects. They're much lower in azithromycin and atovaquone, which is how that regimen became the current frontline treatment for treating babesiosis. If you're unfortunate enough to have a risk factor that puts you at a greater risk of contracting recurrent or relapsing illness, the treatment to resolution of infection is much more complicated. And you can see in this table, these are 14 relapsing patients, and each of the letters is one regimen that was administered to this patient. And you can see there's a whole sequence of them between 2 and 20 different regimens with durations of therapy ranging from 4 weeks to 100 weeks and a fairly high mortality rate. And this, unfortunately, is the standard of care in relapsing patients. So the current recommendation is to treat for at least 6 weeks. And it was based on essentially this case series, which showed that in patients who were given a curative regimen, it was usually longer, 14 weeks, compared to regimens that failed 1.5 weeks. And the guidance really doesn't recommend a specific regimen in these highly refractory patients. There's very much a focus on the duration of treatment overall. The other issue, of course, is the development of resistance to atovaquone and azithromycin. This report came out a couple of years ago. Atovaquone in particular is very susceptible to the development of resistance because it can be conferred through single point mutations in the target gene, which is cytochrome B. Azithromycin is also subject to resistance. And so if you're giving these continuous long regimens, the likelihood that you'll eventually develop resistance is higher over time. When we've gone back and looked at all 44 published case reports in the literature, the cure rate of azithromycin and atovaquone is about 30% when considered in aggregate. So this is why people are interested in new therapeutics for babesiosis, because the existing regimens are too long. You have to give them repetitively, and they're subject to resistance. So tafenoquine is a drug with a different mechanism of action from atovaquone and azithromycin. I've taken these photographs from a paper that came out in 2020, and what it shows on the two left-hand smears are slides from mice treated with just a drug vehicle or with tafenoquine in the middle. And then on the right-hand side is a culture cultured parasites treated with hydrogen peroxide, which of course is an oxidative stress inducer. And you can see the morphology of the poisoned parasites in the tafenoquine slide looks very similar to those in the hydrogen peroxide treated culture, and very different from the normal looking parasites on the left-hand side. And so these authors concluded that tafenoquine acts via an induction of intracellular oxidative stress. And there are a number of other studies and biochemical tests that have also been done that support this idea. So data like that from the non-clinical literature led to a number of investigations of the utility of tafenoquine in combination with atovaquone combinations in the literature. And what I'm showing on this slide is a representative case, and I'll walk you through what the data is showing. The headline statement from this particular study, which came out in 2024, is that in four of four immunosuppressed patients treated for at least 6 weeks until they had at least one negative PCR, the cure rate was very high. So in this chart, in the top table, it's showing the percent parasitemia, which means the percentage of your red blood cells that are infected with the parasite. And closed circles mean positive smears, and open circles mean negative smears. Smears in general aren't that sensitive, so you only see a positive test when you have a fairly acute symptomatic illness. And so these patients are usually also monitored by PCR, which are the boxes below the legend. Closed boxes mean positive PCRs, open boxes mean negative PCRs. And then the different standard of care regimens that were administered are highlighted in different colors over time. And you can see for the first 9 months of treatment, this patient always had a positive PCR and intermittently had positive smears as well. And then when tafenoquine was combined with malarone and mepron at about day 150, you can see that eventually this patient developed negative PCRs consecutively and was considered cured. So we took a look at this data in the non-clinical literature and embarked upon a series of clinical studies. After speaking with the FDA about it in 2024, with the goal of submitting a new drug application for tafenoquine for babesiosis, hopefully in 2027 if all goes well. We have 3 studies actively recruiting patients at the moment. One is a randomized placebo-controlled blinded study comparing tafenoquine to placebo in patients with acute illness who are hospitalized and are also taking standard of care medications. This study's enrolled 28 patients, and we have an interim data analysis in early October, which will kind of set the tone for what happens next. We've got an expanded use study. This is what we call an open label study, so there's no placebo. And this study is open to patients who have failed standard of care treatments and want to try a different approach. And then finally at the bottom, we have a chronic disease study, which is being done at Mount Sinai. This is also open label and evaluating tafenoquine as monotherapy. We've enrolled 9 patients in that study and confirmed the diagnosis in about 20% of them, and I'll explain what I mean by that in a couple of slides. Before we did that chronic babesiosis study, we did a prevalence study. We sponsored a prevalence study at the Bright Spot group at North Carolina State, and they found about a 20% association between individuals who reported chronic symptoms and then were tested for Babesia using digital PCR. So we recently announced in March that the first 3 patients in our expanded access study, so that's Tafenoquine combined with standard of care medications in immunosuppressed patients with treatment refractory illness, they were cured, and we demonstrated that using the blood bank screen that's FDA validated for screening blood donations. And I'll just give you a brief outline of what we're trying to achieve in our chronic babesiosis study, and then share some of the screening data that we've generated so far to kind of bring things back round full circle to where we started the session. So this is a high-level design of our phase 2 study in chronic babesiosis. The details are on the clinicaltrials.gov website, along with the information about how to get involved if you're interested. So we're enrolling patients with chronic babesia, severe disabling fatigue with substantial functional impairment, who have laboratory evidence of exposure to babesiosis in the prior 12 months. We have a goal of enrolling up to 100 patients until we enroll 16 who complete the study. All the patients who enter the study will be dosed with Tafenoquine over 4 days for a load and then weekly out to day 90. The primary endpoint is looking at change in fatigue using a patient-reported outcome. And then at baseline and throughout the course of the study, we're using 3 molecular tests. One is a digital PCR from Galaxy. One is a real-time PCR from the Mayo Clinic. And the third is an RNA amplification test that the Red Cross uses for blood donation screening. And our goal is, the original goal of this study was to try and confirm a diagnosis with the blood bank screen at baseline, and then see if there was any difference in the way patients with a confirmed diagnosis recovered from fatigue compared to those who were on Tafenoquine as well, but we couldn't find confirmatory evidence of infection. So this is where we are in terms of the screening data to date. So we've enrolled 9 patients. I've intentionally referred to patients just with the letter code so all the data stay blinded. In the second column, you can see the types of assays that were used to meet the inclusion criteria of the study. So FISH tests, IFA tests, and immunoblots. The tests were conducted between 6 weeks and 9 months prior to enrollment. And then we've found 2 positive cases in the post-enrollment screening using the Galaxy digital PCR. But everything on the Red Cross RNA amplification screen and the Mayo RT-PCR screen has been negative. So one way of thinking about this data set is that the Galaxy digital PCR is as a genus level screen, and so should pick up any Babesia species. Whereas the Red Cross and Mayo screens are validated to test for specific individual species that are recognized or believed to be primarily responsible for human disease, like Microti and Duncani. So this to us looks like the patients enrolled in our study aren't testing positive for the usual Babesia species that are recognized to cause acute illness. So if you're interested in participating in one of our clinical trials, our website has all the contact information, and I'm showing the links to that here. And I'll stop there, and Joe and I will do our best to answer any questions.
Great. Thanks, Jeff. That was fantastic. Yeah, if you have any questions, just please enter them into the Q&A box. You should see that at the bottom or the top of your screen, and we'll take the next 15 to 20 minutes and see how many we can answer. Jeff and Dr. B, I think you also have access to the Q&A list here, but what I can do is I'll pick out some questions, I'll read them off, and then either of you or both can answer. We have a few that are sort of along the same lines. One, Dr. B, you might be better for this question is we have a number of doctors who get, say, positive tests on a fish, but negative tests for Hygienics immunoblots. Is there any good explanation for that? I mean, I think Jeff alluded to the fact that a fish is more of a genus level test, and then immunoblots are more about species, but it's something that comes up quite often.
Well, we've seen that a lot. And in fact, in clinical practice, that's exactly why we recommend you don't do one type of test, but you do a panel of tests, which include a direct test, such as a fish PCR culture, in addition to the immunoblot, because there's no one test that picks up 100% of the cases. But I have to say something very, very important that I did emphasize. All these hygienics tests, when they went through the validations, were very highly specific. In other words, no false positives. So some of them were 100%, some were in the 90%. So in other words, if you have two different tests and one is positive, one is negative, you believe the positive if it's an hygienics test. Simple analogy, you go fishing, put the line down in the water and you catch a fish. It means there's fish in the water. You don't catch a fish, doesn't mean there's nothing swimming down there. It just means you didn't catch one. So in the case of very highly specific tests like this or like these, you would believe the positive and not necessarily rule it out because one other test is negative.
Okay, excellent. And Jeff and Dr. B, you can scroll through these questions as well. We have so many, we won't be able to get to all of them, but if there are any that stand out, feel free to jump in and take on those. Um, let's
I can,
see.
Nancy asked a question about a lung nodule. The test you do for solid tissues is a straight PCR, and the PCR at Igenics is genus level. So, oh, that's Microti and Duncani, but they will do extended species if you ask. So definitely you want to do a PCR on any solid tissues for testing.
Okay. There's a few questions about the length of time someone should be on tafenoquine. Jeff, is there any guidance along those lines or no?
So what we have heard anecdotally is people tend to feel some benefit between 60 and between 2 and 4 months. Usually it takes that long before anecdotally there's some relief reported from symptoms. And I'm hesitating a bit because I have to be careful how I answer questions like that. I think from a parasitological perspective, the relapsing immunosuppressed patients, in the successful cases where tafenoquine was combined with other medications, all of those patients were on medication for at least 6 weeks to get to the point where you began to see negative PCRs. That doesn't mean the infection's eradicated at that point. It just means you're getting a reduction in parasite burden. So that's what we know based on the literature and anecdotal experience at the moment.
I can just add something to that. Babesia are red blood cell parasites, and red blood cells have an average lifespan of 120 days. Those that are infected have a shorter lifespan. And my advice has always been to treat for at least 3 months because you want to get all the Babesia and all the red cells before they recycle. So my minimum treatment for Babesia, chronic Babesia, is 3 months, and 4 might be better.
Great. Um, Here's another question, Jeff, you might need to be careful with. Can we use tafenoquine now off-label for Babesia? I think it's available for malaria prophylaxis.
So it's available if you take a prescription to any pharmacy in the country for malaria prevention, you're able to get Arakota. Sometimes they don't stock it because it's not a widely used medication, and so you might need to push the pharmacist to make some inquiries sometimes. But generally, we found that patients who need it for malaria prevention are able to get it fairly straightforwardly. It's also available through Amazon Pharmacy and through InfuServe. Both of those organizations will deliver to a patient's home. And then there is a GoodRx coupon as well for folks who need the medication for travel but don't have insurance.
Excellent. Dr. B, I see a few questions, just general questions about like co-infections and multiple infections at the same time. Just kind of some basics on, can people have more than one infection? I mean, what we're talking about now tonight is Babesia, but it's considered a co-infection of Lyme. And so can you maybe just talk a little bit about the fact that someone can have multiple infections at the same time?
Well, sure. Ticks, they're nature's dirty needle. They draw the blood of wild animals, and, they have definitely going to pick up more than one infection. And the great majority, in my experience, of chronically infected Lyme patients have more than just Lyme Borrelia. They can have other Borrelia along with the Lyme. They can have Babesia, and it can be more than one species. They can definitely have Bartonella and the Rickettsias. So co-infections is kind of the rule rather than the exception in the chronic patient. And I actually feel that people who don't get a co-infection are those who are the lucky ones that get a short treatment and they seem to be well. But those who get treated and don't get well early on, they probably have a missed co-infection, and that's why they're in trouble. While I have the microphone, I gave a presentation tonight on diagnosis, but with treatment, I have to add one other thing. The commonly used Babesia treatments, including Tafenoquine, all interfere with the way the life's process goes on in the Babesia. In other words, here you've heard that Tafenoquine works to, cause oxidative stress. Drugs like atovaquone, that works on the production of energy. So one of the rules that I have, and one of the things that we've been doing for years, if not decades, is not give people high doses of vitamins that would support metabolism. You don't give CoQ10, for example, when someone has Babesia. With Tafenoquine, you don't use high doses of antioxidants or vitamin C, unless you use very high doses of vitamin C IV, which is a pro-oxidant. But low doses or standard doses of antioxidants are things I tend to avoid when I have a Babesia patient who's under treatment.
Excellent. Jeff, I'm seeing just a few questions about how folks can participate in the study. Can pediatric doctors and their patients participate? I just maybe any general information. I believe going to the website might be the best place to get more info.
Yeah, so the three studies I've highlighted on this last slide, the details are available on clinicaltrials.gov, and there's an email to send us inquiries at the bottom of the slide about how to participate. We don't have a label for kids yet. We're obviously aware that there's been some off-label pediatric use for Tafenoquine for various things in kids. So we are talking to a couple of the folks who treat PANS and PANDAS kids about whether there might be a way of doing some sort of post-marketing study once we get through the FDA process for the adult indication. It seems to be something where there's a lot of unmet medical need and people are very passionate about. So No firm plans yet, but we are thinking about it.
Got it. Got it. Um, Another thing I'm getting a question. Jeff mentioned tafenoquine and standard treatment in the B-Free trial. What is the standard treatment, and does that include atovaquone?
So in the B-Free study, which is our chronic disease study, we're giving tafenoquine as monotherapy. And that's partly because there are no treatment guidelines. And so to get ethics approval to do that study, monotherapy was acceptable. In the immunosuppressed patient study where we're combining tafenoquine with mostly with atovaquone and azithromycin, but a couple of other drugs, it has to be combined with those other drugs in that patient population because it's probably unethical to do monotherapy in that context, given what we know about the history of needing to combine multiple drugs to get successful outcomes.
Great. Maybe Dr. B can handle this one. So is indeterminate considered a positive? This is something that comes up quite a bit from doctors when they see an indeterminate. And I'll just throw out my 2 cents real quick. I mean, from what I hear, a lot of it can depend on what band is indeterminate, like in a Lyme immunoblot, for example. That's something I heard, but certainly Dr. B, I'm sure, has a better answer for that.
Well, with an immunoblot, the standard for testing is based on statistics. So, for example, two bands or more have a 97 to 99% chance of being a true positive. A single band, the percentage, I don't know exactly the number, but it's much less. So when you have one band, the lab calls that indeterminate. Now, what does that mean? It means a few things. Could be that the immune response is weak and you just don't have enough antibody to show up more than one band. It could be that it's an atypical organism that has some cross-reactivity. One of the more atypical Babesia species, or like the Colpodella that was found, for example. Another thing could be that if someone has an overwhelming infection, the antibodies which bind to the organism, they bind all of the antibody. The organism sucks them up like Pac-Man. And when you do an antibody test like an immunoblot, you're not measuring the total amount in the blood, you're measuring the amount that's freely circulating. So if there's a lot of organisms, an overwhelming infection, it's sucked up, it attracted and attached to all the antibodies. There's no free antibody left running around. So that could be a case where you get a borderline or a false negative test as well. And that's why after treatment, some of these people become now positive again because the number of organisms, number of Babesia are less, and there's now more free antibody. Another question about Otocolii. Otocolii is so very close to Duncani genetically and serologically that many times a positive Duncani is thought possibly cross-reacted with Otocolii. But in the case of IGeneX, the immunoblot does pick up Otocolii. It'll either be reported as Babesia species or as possibly Duncani. This is not official from the lab. This is just what others have been saying. So we'll pick it up on an immunoblot, and because the culture and the fish are genus level tests, it definitely will pick up Otocolii.
Excellent. Jeff, I'm seeing a couple questions about, does tafenoquine have any impact on other tick-borne diseases like Lyme or Bartonella, or is there any data or research on that?
So a few years ago, we did some antimicrobial screening on a variety of bacteria. So gram-negative bacteria, which is probably the most relevant to the discussion. Tafenoquine was less potent, probably about 4 to 10 times less potent against bacteria than it was against fungi. And when we did animal testing with tafenoquine against some lung fungal infections, we got a little bit of a reduction in fungal burden. So it does have a slight effect, but not enough to kind of develop fully on its own as an antifungal. So because it's less sensitive, or because bacteria are less susceptible than fungi generally, I think you'd probably need to combine tafenoquine with other agents to see an additive effect on bacterial infections generally. And I'm not aware that anyone's tried doing that in an animal model yet. And as it relates to Bartonella, it's incredibly hard to do those testing with tafenoquine because the cell lines that are used to do the work in are susceptible to the drug as well, and so you can't get any resolution between. So they're just methodological issues which have made fully assessing that challenging, and I'm not aware that anyone is working on that actively at the moment.
Excellent. Yeah, maybe we'll take a couple of more questions here. There are so many, I apologize, we won't be able to get to all of them, but we'll certainly try to follow up after the session with answers to these questions as we have your contact information from Zoom. Here's a question that either of you, I suppose, could answer. How important is it to know which type of Babesia you have when it comes to treating with tafenoquine or atovaquone or any of the general treatments?
Do you want to have a go at that one, Dr. B, and then I'll add to what you.
Well, there's not any research data that can back up what we're seeing clinically, but the general consensus is that microti is more easily treated than duncani and the others. But in terms of the type of treatment, I don't think that, in my experience or what I've read, that different species require different type of treatment because the treatment works the same mechanism regardless of what species it is.
Yeah, I generally agree with that, and I would say that in chronic disease we have almost no research data to be more informative than the anecdotal experience. Do you agree with that, Dr. B?
Yeah, I do.
Yeah.
Super. So I'll let Jeff and Dr. B give a couple closing thoughts of their own here in a second, but it's the top of the hour and I want to be respectful of everyone's time. I just want to thank everyone for being able to join us on tonight's call. As a reminder, the slides and the video of this presentation will be available before the end of the week on the IGeneX website. So we encourage you to come back. It'll also be on YouTube and a couple other platforms. And so you can rewatch that. So yeah, Jeff or Dr. B, either of you can, just give a closing statement if you like, summarize your thoughts about the evening and anything else.
Oh, I can start. I just want to say that Babesia is probably more common than people think. The really worst cases of Lyme usually are Babesia related. Babesia is immunosuppressive, and that could be why people with Babesia do end up with reactivated viruses and persistent SARS and so forth. So really, really consider Babesia. And my best advice from testing is don't do one test, do a panel of tests. We include the immunoblot to see what your immune system is doing, to do the culture because it will pick up the really strange atypicals, and to do the FISH, which is a genus level test, will pick up all the different clinically important species of Babesia. And finally, as I mentioned more than once, IGeneX tests have a very high degree of specificity, meaning no false positives. So if you get a positive IGeneX test, it doesn't mean it's being overread. It means it is a real positive, and do not ignore it.
And I guess I would say that just thinking about where malaria drugs were in the 1930s, before it was 7 days to 2 week regimens, 3 times a day of drugs like quinine, which have nasty side effect profiles. And yet, almost 100 years later, the gold standard, what we call a product or target product profile for a new malaria drug, is a single dose treatment for all types of disease. And we aren't there yet with malaria, but it might happen in the coming years. And then you have to ask the question, why isn't a wealthy country like the US, where there's no malaria at all, not able to achieve the same thing for treatment of Babesia in our own backyard? So that to me is like the kind of the moral problem. In terms of what we're trying to do to solve that, we have a drug that's commercially available and shown to be safe for its intended indication for, up to 6 months of use. And we're doing the best we can to prove efficacy in babesiosis within the context of, the existing standard of care, so that firstly, we have a drug that's been blessed as hopefully safe and effective by the FDA. And secondly, to essentially model the way for new drug development so that the next series of treatments can have shorter durations, be more applicable to a broader range of patients. And this disease becomes something that's annoying as opposed to life-changing. I'll leave it there.
Excellent. Thank you. Well, thanks again, everyone. And thanks, Dr. Dow, and thanks, Dr. Burrascano, for taking the time this evening. And yeah, please check the IGeneX website later this week for the recording and the slides. And until next time, be well. Bye now.
Night. Bye-bye. Thank you all.
Good night.